Welcome to Robert Wood Johnson University Hospital, Somerset's Health Talk. I'm Dr. Douglas Oshinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Asian Indians are one of the largest ethnic groups in central New Jersey. Due to genetic, cultural traditions, and diet, Asian Indians are at higher risk for some diseases than other groups, such as diabetes, heart disease, and certain cancers. On today's show, we will learn more about the unique health conditions facing the Asian Indian community and how Robert Wood Johnson University Hospital Somerset's new Indian medical program is working to help promote early detection and prevention and increase access to medical care. Today, we are joined by Dr. Alpesh Patel, a cardiologist with Robert Wood Johnson Physician Enterprises Cardio MD, and Shisha Patel, the coordinator of Robert Wood Johnson University Hospital Somerset's Indian Medical Program. Welcome to the show. Welcome, both of you. Shisha, first tell us a little bit about your background and what got you interested in doing this program with Robert Wood Johnson.
Okay, so my background is I received my bachelor's degree in pre-professional biology from Kean University, and then now I'm pursuing my master's of public health from Chamberlain University based out of Chicago. I got the interest of public health when I was doing my internship at CINJ, Cancer Institute of New Jersey, which is located in New Brunswick. I was doing a colorectal cancer screening prevention program for the Indian community where my interest in public health came across, and I decided to pursue a degree in public health. So that's where my interest started. And then ever since then, my focus was the Indian community. I started with Robert Wood Johnson Somerset Hospital in the community health department, working as a community educator, doing community educations in the Indian community for breast cancer. And now I am in this new role of Indian Medical Program as an Indian Medical Program coordinator. And I help the Indian community to get closer and improve their health outcomes and eliminate health disparities.
First of all, congratulations on your accomplishments, and congratulations for doing what you're doing in public health, and especially for the Indian medical community. You know, as part of Robert Wood Johnson, they're out there trying to bring in and add to the medical care all of this public health information, which most people don't understand. And what you're doing is getting that education out there and helping their medical care. Dr. Patel, you want to tell us a little bit about yourself and where your practice is?
Sure. I graduated out of Rutgers University. My major was molecular biology, biochemistry. I minored in adolescent psychology. And then I went to medical school. Before going to medical school, I did research at CINJ, Cancer Institute of New Jersey, but obviously at a lot longer before that.
Right.
But once I started my medical school, I graduated, and then I did my internal medicine residency at Seton Hall University, and then I did my cardiology fellowship at University of Buffalo. And then I came back, and I've been working since then. And a year and a half ago, I joined Robert Wood Johnson Physician Enterprise. And right now, I work with Dr. Shahi and Dr. Mahal. Our practice is located in Bridgewater on Route 22 at the Graymark building.
First of all, congratulations also on all of your accomplishments, and mostly a New Jersey person other than University of Buffalo.
That's right.
Okay, so since we're talking about Asian Indian health, as you know, there are lots of increased disease processes and common health issues in the Indian community. Do you want to discuss, both of you, discuss what the Asian Indian community needs to think about to help better their health?
Sure. Some of the things they need to think about is, which is universal across all groups, diet. If you look at Asian Indian diet, it's very heavy in cheese, fats, ghee, which is what we call it. It's essentially a butter, but a mother of butter, so to speak. So that diet is an issue, but that remains everywhere else. Also, it's a lack of exercise. Studies have shown that Asian Indians tend to exercise less compared to other ethnic groups. They also tend to drink less alcohol. As you know, that drinking moderate alcohol is, of course, good for your heart. So there are all these risk factors that play a role. It's an interplay of different things that leads to increased incidence of heart disease. And like you said, it is a very big issue because Asian population in general represents about 25–30% of the world population. Increase of coronary artery disease is very, very prominent amongst the Asian people. In the United States, for example, the rate of coronary artery disease is about 2.5%. Do you want to guess what the risk factor would be for the Asian Indians?
10%.
So you're right. 10% in the Asian Indian population who don't have diabetes. It goes up to 20% who have diabetes. And of course, with other risk factors, it's an additive effect. You add hypertension, high cholesterol, which also happens to be more prevalent. So all of these, like I said, it ends up with one result: increased prevalence of coronary artery disease. So it is very important, and I think, and I'm very grateful that Robert Johnson and we, Physician Enterprise, the hospital, we are all trying our best to somehow control that, to do the best we can to serve this population.
As a primary care doctor, with everyone coming in, no one's treated any differently. We all treat everyone the same. What we have to think about is that when an Indian Asian person comes in, one, they have an increased risk of hypertension and heart disease versus the Caucasian population. Diabetes, unfortunately, seems to be much more prevalent in the Indian Asian population, so it's very important that we jump on that as quickly as possible. Three, unfortunately, is that cigarette smoking seems to have a much higher prevalence in the Indian Asian population than in the Caucasian population, and it's much harder, since it is something that is cultural, to try to convince them that stopping smoking is important. It's also part of their socialization when they get together. That's something that actually is very important. Number four is the fact that there's increased risk of colorectal cancer, lung cancer, and unfortunately prostate cancer in the Indian Asian population. So even though we're supposed to be treating everyone as as the same way, I've still got to individualize the care. And so again, I'm going to send more people who are of Indian Asian descent to the cardiologist to ensure that we are finding things early. I'm going to, as you said, in public health, you did a whole discourse on colorectal cancer.
Correct.
And it's so important because of the increased incidence of colorectal cancer in the Indian Asian population. It's something that if we do outreach, we may be able to find much earlier than if we don't do outreach. Now, being that you're doing this with Robert Wood Johnson, what are you doing to help with these people?
So we do a couple different things. We do screenings. We are doing education. I think education is very helpful, more so than screening, educating people, telling them about their health, about preventive care, about things they can do to prevent from getting illnesses and life-threatening conditions is very important. So we're trying to send our community health educators out in the community, and we're trying to cater the education programs in language to make it easier for the community to understand and comply with treatment and prevention options that are out there. And that's the education part of it. We're also doing screenings. Like Dr. Patel mentioned, our top 3 health challenges now are cardiovascular disease, all different sorts of cancers, and diabetes. That's very prevalent in the Indian community. So we're doing screenings based around those. We're doing blood pressure screenings, blood glucose screenings. We're doing diabetic foot screenings. We're doing all different sorts of screenings to help the community, and also education along with that.
So as the coordinator, what are you doing? Again, I've got someone in my office who comes from that part of the world, and the thing that you talked about, which was very important, is the dialect. They may not have the English language 100%, And do you have people in your, who do you coordinate who understand the different dialects?
So currently we only have one navigator who speaks Hindi and Gujarati, and that's obviously me. We are trying to build this program, so as we build the program, we are planning to hire more individuals who speak all the other different dialects. But we have a language line that's available at every physician's office, at the hospital, that all of our physicians and nurses and the entire staff utilizes. But our Indian medical program sort of gives a personal touch, and patients feel more comfortable when there's someone personally there trying to help them through the process.
Well, the fact that you know and can do two different dialects is important, because you can actually, there may be nuances in the words that I can't say to the person that you can say, and may get them more motivated, because motivation is important. Unfortunately, it's been found in the past that with Indian Asians, they're not ones who really seek out the prevention, the screenings, and if they've got someone who they can actually talk in the native language with, maybe they'll feel more comfortable coming to the screenings.
Right. So the purpose of the program is to take the burden off a family member, to help them, even with translation, interpretation. The patient might not be able to convey the message to the doctor appropriately. Sometimes we have phone lines doing the translation, but it's the visuals that, while interpretation to the doctor, I think the visuals also help. Sometimes there's words that a patient is trying to describe. It's not easy for the doctors to understand. So there's often better to have a translator, especially someone in person, to be able to convey that message, and vice versa. Conveying the medical terms to the patient and making them understand what they really need to do to better their health is very important. So we also help, we have a medical dictionary that in our language that we go through, and we help patients learn about their illnesses, their disease, their condition, which I think gives a personal touch for them to understand, then rather than just telling them in English what it means, and that's the end of it. So there's often patients that know that they might have Parkinson's, not knowing what that exactly is. So as a navigator, we also help patients understand what that means.
And you are located where? At the hospital itself?
Yes, so my office is at RWJBarnabas, Somerset, but I also travel and I accompany patients through their doctor visit, whether they're coming to the hospital for testing or physician offices. I accompany patients to sort of a comfort level.
Which actually is one of the differences between your program and many of the other programs, the fact that you, who, again, understand two dialects, have the background, also the dictionaries just in case,
right,
that you actually accompany the patient to the physician office or to the hospital to help. Explain what that means.
So in my role, I basically help patients from finding doctors, specialty doctors, making appointments, care coordination, arranging transportation, filling out paperwork, interpretation, translation, and obviously accompanying patients to their appointments, sort of to improve compliance and lower the rate of emergencies. So there's lots of patients that I found that have prescriptions that, if a patient is given a prescription, for example, Pap smear, they don't know what that is. So they have piles and piles of scripts sitting at home not knowing what to do. So now that this program came into effect, I have patients every now and then bringing me a prescription, not knowing what to do, where to go, how to set up an appointment, what are the things they need to do in prep of the appointment. So I sort of get the preps from the testing centers. I translate them either Hindi or Gujarati, and I email it to them or fax it to them, so it's easier for them to understand and properly prep for their testing.
Which again, it's so important what you're doing, because I can have all the screenings possible, but if the person or the patient doesn't understand, one, why I'm sending them there or what is necessary, they'll probably not go. And if they don't go, we may miss out on preventing something that could potentially be severe down the road. We can reduce the risk of the problems by having someone like you do what you do, and the fact that you have people that, again, Robert Wood Johnson University, Somerset, getting more and more into this, understanding that there are cultural and genetic differences, and by doing this, we can help prevent the problems down the road.
Yes. So it's absolutely important. I think another big piece is that a lot of our patients are hesitant to go to the doctor simply because there's lots of, culturally, there's lots of home remedies that our patients tend to want to do before they actually need to see the doctor. Another important thing that I found that they don't believe in follow-up cares. They feel that they need to seek out for medical help when they're severely sick or where there's some sort of out of order thing happening to them. That's the only time they seek for medical help, and which I think we're trying to educate our patients that preventive care is very important. Prevention is better than cure.
Which again is part of your whole public health education.
Absolutely.
Is the fact that rather than treat the acute process, if we can prevent it and prophylax it, maybe we avoid the acute process and they live a better life.
Absolutely.
They go to the cardiologist, and what do you do?
So when they come to me, my challenge is, the typical challenge would be that, a 40-year-old patient comes in and says that, I'm having chest pains. And, they read the literature, they look at the news, and they say that, 40-year-old age is sort of on the younger side, I probably don't have anything. Well, I mean, studies have shown that they can have coronary artery disease at the age of 40, much more common than the Caucasian population, for example. So and this is a problem for all immigrants when the first-generation immigrants that come over here. They have a higher risk of coronary artery disease in India. And usually in India, again, like we talked about, the numbers range from 10 to 20%. When they come over here, they carry that risk with them. And it's not the same risk profile as your average 40-year-old Caucasian person. So then they compare themselves to other people and they say, oh, it's nothing, and they'll just ignore it. Or in terms of screening, and I don't mean to say this on TV, but for example, my parents, they have not done colon screening. They have not done colon cancer screening. And it's very difficult to either talk about screening or coronary artery disease and communicate to them that this is an important issue. You are different, you fit into a different category, so we need to address you a little bit differently. You need different workup. We have to be much more aware of the possibility of coronary artery disease or any kind of cancers or any screening or whatever it is. So if when Shisha brings the patients to me, I mean, I luckily speak Gujarati and Hindi, and I think a little bit of English, but but so I can communicate with them, and that is the challenge. Coming up, when a patient comes and sees me, ordering a stress test or whatever that's necessary, that's a very simple task. Before you enter the room, you know what the patient is most likely going to need. But to convince the patient that this is the thing we need to do, and more importantly, convincing them to change their dietary lifestyle, dietary habits, change food at home, less trips to Oak Tree Road where the food is delicious, and I go there more often, but all that stuff. So that is much more challenging in my opinion. But that's where I pick up. So Shisha brings the patients to me, and then I pick up from there and I do my job. So together we try to accomplish the goal of reducing this, treating anything that needs to be treated, diagnosing anything that needs to be diagnosed, and as such.
Well, it all goes back to, again, public health.
Exactly.
We have guidelines, And the guidelines are very good guidelines. We also have to add the individualization of the guidelines based on the person's genetic makeup, cultural makeup, and unfortunately the fact that in the Indian Asian community, smoking is part of their social life. And we know what smoking does. It increases the risk of coronary artery disease. It increases the risk of lung cancer. It increases the risk of peripheral vascular disease. It increases the risk of stroke. And the fact that we have an Indian medical community coordinator may be helpful in disseminating the information about cessation of smoking. And again, not only that, but you can coordinate with the Smoke Enders program at Somerset Hospital and hopefully get them to cease smoking over a period of time.
Yes. But the convincing part is the hardest. That's why my position kind of overlaps with community health department and education. So I feel like education is our first step. Convincing them to do the screening is another step, and then finally leading them to see a doctor, a specialist for their problem is the next. That's the ultimate goal.
And the follow-up afterwards, actually even more important, because
That's
they'll
right.
go that time, but will they come back for the follow-up? And if it's a colorectal screening, are they going to come back in 3 to 5 years for another colonoscopy? Are they going to continue to follow up? And then they change, and then unfortunately, the Indian diet may not be good, but the American diet is even worse. And it's convincing them that a more vegetarian type of program is acceptable and better for them. And again, that's the education part that you are helping them with to help reduce the risk of complications of all of this down the road.
Absolutely, yes.
And it's not easy.
Oh, no, it's not easy. I agree. It is not easy because it all comes down to patients realizing, first of all, they have to accept that there's something wrong. Culturally, if you accept that you have high blood pressure or if you have possible coronary artery disease, you're having chest pain, the first inclination is that there's something wrong with my body. And how could that be? And that usually leads into, unfortunately, ignoring the problem rather than addressing the problem. And that's culturally, and I'm sure it's everywhere, but I've seen that more often in the Asian Indian population. So yes, you're absolutely right, is that convincing them to come in, convincing a follow-up, it's very different. But at the same time, like I said, it is very important to address, not just, so in my cardiology practice, for example, it's not just addressing that, okay, fine, you came in, coronary artery disease, it's fine, you don't have coronary artery disease, we'll see you back or follow up with the primary care and I'll see you back in whenever you have a problem. What I try to do is, okay, fine, first question I always ask is that, what did you have for breakfast? What was lunch? What was dinner? And out of those three things, tell me what helped you with improving your cardiovascular health. And the answer sometimes is not encouraging. But for those kind of risk factors, you want to bring them back over and over again. Okay, fine, you exercise, fine. Exercise, establish a program for yourself, whatever you feel comfortable with, do it, and then come back and see me in 6 months. Or see your primary care physician. And that's where the collaboration comes in, is between the hospital programs like Shisha's, primary care physician, specialist cardiologist. So all three of us working together, that is the goal, is to keep the patient on track towards reducing, from my standpoint, cardiovascular health problems, and from Shisha's and everything else, reducing risk of cancer and everything else.
Against the team approach again.
Exactly.
I can't do it myself, you can't do it yourself, and Shisha can't do it herself, but
Absolutely.
Working together, and especially with the leadership at Robert Wood Johnson Somerset, understanding how important this is, and not just saying, oh, it'll get fixed. They're doing something to fix a major problem, especially because of the population in central New Jersey. They're helping to reduce down the road problems. They're helping through your public health, through your education, through your being the navigator for this program. We're reducing the complications and problems down the road. We're helping to modify the cultural and factors that the people have, and hopefully making them a better, longer life, less problems, less medications, and actually enjoying life fuller.
Yes, that's the goal.
And the fact that you also understand the dialects also, which is very important. It's very different for a person to come into my office and I don't speak their language. It's a little bit, they push back a little bit, but if you're there to help translate, they understand that not only is the doctor trying, but the system itself is doing something and helping me. They're not putting a roadblock in front of me. They're actually giving me something. They're not charging me for it either. I'm not having to take out my checking account or taking out a charge card to do something that's helping me down the road. And then you're doing the outreach to the community to actually look, even though these people may not be coming in for their specific thing, you're sending out these outreach so that we find people before something happens. And it's wonderful what Robert Wood Johnson Somerset is doing in this regard, the fact that they understand the diverse population that central New Jersey and northern New Jersey and each part of New Jersey has, and that they're employing people such as you to bring that into the whole system. And the fact that you have the whole public education background, so you understand the statistics, you understand what we have to do. And the fact that we have terrific physicians such as Dr. Patel who are willing and able to help that and who just don't stop at the acute process, but understand the long-term care that's necessary to help improve the Asian Indian population.
Absolutely.
Any last thoughts?
So I just wanted to add on that onto what you said, that this program is complimentary. It's free. There's no charge for this program whatsoever. And my direct number for this program is 908-595-2348.
Can you say that again?
908-595-2348.
Thank you very much, and thank you both for coming here.
Thank you. Thank you so much.
This concludes today's episode of Robert Wood Johnson University Hospital Somerset's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-888-724-7123. For more information about the Indian Medical Program at Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjbh.org/Somerset. And one more time, your phone number?
908-595-2348.
Thank you both for being here.
Thank you. Thank you for having me.
And thank you for helping the Indian Asian community.
Absolutely. Thank you for having us.